I would like to thank the New York County Psychiatric Society, which is the district branch of the American Psychiatric Association, for putting this event together. We also want to acknowledge PRMS for sponsoring this event. So Mr. Rich Sagnato from PRMS. Rich, please say a few words.
Thank you, Dr. Vito. It's great to see everyone again. We've been, platinum partner of the New York County Psych Society for years now. I mean, we know how long it's been. It's been a hot minute. So it's great to see everyone and see everyone's backgrounds and homes and everything. That's always kind of cool. After the event, we'll be, receiving some information either through us or the branch here that are related to obviously COVID-19 of all things. So some resources. Some of it is on our website as well at prms.com/FAQ. We'll also send some information that has been updated and it may not be on the website as well. So hope you find the information useful from us as well if you've ever seen from your other sources and hospitals and colleagues. With December, it's the season for giving and things like that. So we are PRMS is making some donations as well to a local food bank we have here in Arlington, Virginia, as well as to NAMI and Craft Glove, which is an organization which provides knickknacks and goodies for kids who are in hospitals and are going through various treatments. On a more lighthearted note, also everyone knows about a referral program where doctors refer their colleagues to us for insurance coverage. Whether or not they buy, we let the referring person choose which organization, including New York County Psych Society, where they want the donations to go. And we're running a little bit of where we're paying an extra donation to the chosen organization of the person or group who refers the most doctors. We hear a lot from New York folks as well. So my fingers are crossed for y'all. Anyways, thanks again for having us. It's great to see everyone. And I'm not sure if I'll be with any of your next events the rest of December, but if not, enjoy the holiday season and New Year's and hope each other in person next summer, fall, maybe next winter, who knows. But again, it's great to see y'all. And, again, thanks for having us.
Thank you, Rich. As always a pleasure seeing you. Again, my name is Dr. Jose Vito. I'm your elected representative to the APA Assembly and also on the Executive Council. I'm also an addiction clinical assistant professor at NYU School of Medicine. So tonight, we are very fortunate to have such great dynamic speakers. We have Dr. Christopher Fuller Lewis, Jeremy Kitt, Shabnam Shakibaie Smith, Jonathan Avery, and this Berthy. So the format for tonight's event, the speakers will each have 5 minutes to talk. If you have any questions or comments, feel free to type it at the chat box at the bottom of your dashboard. We will constantly monitor them. We want this event to be informal and engaging with the audience. So sometimes as the speaker talk, we will be putting in some questions as well. So in addition, I want to introduce you my co-host, Dr. Mary Rockas.
Good evening, everyone. My name is Dr. Mary Rockas. I'm the co-chair of the residency committee for NYCPS and a third-year resident at NYU who's interested very much in addiction fellowship.
Thank you, Mary. Our co-moderator tonight is Dr. Alan Rodriguez Penney.
Thank you, Dr. Vito. My name is Alan. I'm your elected secretary of NYCPS, and I'm currently I'm a psychiatrist. I work at Janian Medical Care, serving people with lived experience of homelessness. Thanks for coming.
Thank you, Alan. So tonight, our first speaker is Dr. Christopher Fuller Lewis. She is an associate professor of psychiatry at NYU School of Medicine and director of the Social Solutions and Services at NKI. She has been selected as the recipient of the Laurie M. Tisch Scholar for Racial Equity in Mental Health. Her talk tonight is on addiction and intersectionality with race during COVID-19 pandemic. So welcome, Dr.
Thank you. I got it. I turned it on. Okay, so I apologize for the background noise. I'll go quickly and I'll mute as soon as I finish talking. I'll try to mute and unmute throughout the evening. So thank you for this opportunity. I think this is a very important forum for us to have this discussion, and thank you all. So I'll get deep right into it. The term intersectionality, anything can intersect, but it's become popular in research and practice now, and typically refers to intersectional stigma. So when people think of intersectionality, they're thinking of typically intersecting social statuses that one might be experience discrimination or stigma with respect to, or it could be any physical or mental health condition. And I think that those of us who've been doing disparities research, we know that there are differences by different social statuses, by race, and we've always looked at different types of stratified data, and with the understanding that there's different things going on for different populations. But intersectionality really brings to the forefront that perhaps these things can't be teased apart, and we need to rethink how we look at individuals, communities, populations who are struggling with a lot of different aspects of their identity that they might be experience discrimination or stigma. But in general, stigma is a social construct, and it has everything to do with othering individuals or communities, stereotyping. It operates on multiple levels, individual levels, interpersonally. You might anticipate that you're going to be treated unfairly because you've experienced it sometime in your distant past, or intergenerationally, interacting with providers, with your family members. Also, there's institutional and structural levels of stigma and discrimination. And one important I was thinking, what can I talk about in 5 minutes to stimulate thought? And I think when it comes to addiction, the most glaring example of how stigma operates on an institutional, structural, or policy level is how we treat different populations who have addiction. When I speak of addiction, my personal background is with more serious street drug use, forms of addiction, heroin, crack, cocaine, K2, and populations that are typically disconnected from care and services and treatment. So that's sort of where I'm coming from. And the fact that overdose has been occurring among majority Black and Latino, or disproportionately among Black and Latino populations for generations, decades, and it wasn't until the opioid epidemic escalated and became was experienced at a crisis level among white Americans that it received attention both from policymakers, practitioners, research, NIH, CDC, you name it. And so this is actually a very good example of institutional or structural stigma or discrimination and how it can affect a population. So you can imagine somewhat in another good example, just kind of drilling it down to treatment, is the availability of buprenorphine. When I first arrived to New York in 2000, 2001, 2002, buprenorphine was, I went to some exclusive, launch of buprenorphine, and how this was going to be the drug that saved, a middle class, wealthy, white Americans who come to their physicians and they have a drug dependence problem, and they didn't want to have to use any community services, so the physician could prescribe them something and during their office visit, and there was absolutely no intention on making buprenorphine available or providing services to make it available to the community. And this was my welcome to New York experience with addiction. And so fast forward to today, you know, these are things that, again, because of stigma, this is how history kind of plays itself out. I'm going to stop there because I feel like I've already gone 5 minutes and have taken up too much time with my blender. And I'll mute myself.
Well, Dr. Lewis, we actually have a question. There's actually a question for you. So what and why is intersectionality important for our understanding of addiction and the role of race?
I'm sorry, can you repeat that? I know I sent you some of these questions.
Sure. The question is, what and why is intersectionality important for our understanding of addiction and the role of race?
Yes. So I think given what I've just said, and when you think about the role that race plays, I'm going to drill down from an institutional and structural level and kind of talk about individual and interpersonal forms of intersectionality and stigma. And I think the most important thing is for us to understand is that we need to come from a place of humility and not knowing and not assuming that if someone doesn't express that they're experiencing stigma from various sources or various parts of their identity doesn't mean that it's not operating, or that it may not look the way that we might think it should look. And as researchers, this is something that we're beginning to understand. For example, we might, for years we've been studying, we ask people, do you feel you've been mistreated because of your race? Do you feel you've been mistreated? You know, we go down a laundry list. Sometimes they say yes, sometimes they say no. And then we ask in different venues. And then we put this all in a model, and then we say, oh, the most important discrimination is because of drug use. And this is an actual analysis. But does that mean that race doesn't play a role? Well, not necessarily, but I didn't probably ask it the way to capture it and really see the nuance of it. Because as individuals, as all of us are, we don't walk through the world with just one identity and just feel one thing all the time. So I think that kind of stepping back and rethinking what it means in the totality of someone and what that means for them and their family, their generations, and not every single person with all of these identities is going to present the same. So there's no such thing as coming into a space, engaging with a patient, with a certain population, with a community, with an individual, and thinking, okay, I know exactly what this person is contending with. So I think without coming from a place of not knowing, I think is the best strategy, and being open-minded and understanding that people may not tell you about all these different statuses, but they very well may be operating.
Thank you, Dr. Lewis.
So I wanted to continue on to the next speaker. First of all, thank you for the talk, Dr. Lewis. And our next speaker is Dr. Jeremy Kidd. So Dr. Kidd is a Columbia University trained board certified psychiatrist and an addiction researcher. And he is also your elected executive counsel on NYCPS. And today he's going to talk about addiction and the LGBTQ community during COVID-19. It's good to have you, Dr. Kidd, and thanks for joining us.
Thank you so much. So I think in recognition of what Dr. Lewis was saying, I will sort of echo that and remind you that I'm going to be talking about addiction in LGBTQ populations, but that what the data I present about LGBTQ populations says things about that population in general and doesn't really say very much about the individual in front of you. So I think it's just important to keep that in mind, that when I think about addiction in LGBTQ or lesbian, gay, bisexual, transgender, and queer populations, this is really, during COVID, this is really a story of first understanding what was happening before COVID. Because I think a theme that you'll see with a lot of the data about mental health and substance use during COVID is that disparities that existed before COVID did not go away during COVID. in most cases, they got and I'll talk a little bit about that with regard to LGBTQ populations. But before COVID, in 2015, the National Survey on Drug Use and Health, which is administered by the by SAMHSA rather, the Substance Abuse and Mental Health Services Administration, for the first time included a sexual orientation measure in that data set. And we got our sort of first population level glimpse at substance use. There have been lots of studies about substance use in LGBTQ communities before, but they used convenience samples, often venue-based sampling, so less generalizable. And so this data showed that across most substance categories, whether we're talking about cannabis, whether we're talking about prescription pain relievers, cocaine, hallucinogens, and opioids, which is important. For the first time we had some opioid data, showed significantly higher rates of use and use disorders of many of these things, DSM-5 use disorders, within lesbian, gay, bisexual individuals, sexual respondents. And the NISDA, and in fact, virtually all population level surveys do not include a measure of gender identity. So we don't have any data to talk about trans folks, but I'll talk about some perhaps later in the Q&A. And one of the ways of understanding these disparities is extending what Dr. Lewis was talking about, the role of stigma, discrimination, and an internalized stigma as well, particularly relevant for LGBTQ folks. And this was conceptualized in 2003 for LGBTQ folks by Alon Meyer with the minority stress model. And since then, there's been a lot of work looking at these three constructs: discrimination, societal prejudice or stigma, and internalized stigma, and associating those with many of the health disparities that we see for LGB and then T folks as well. That work was done by Hendricks and Testa about a decade later. And during COVID, you know, what we've seen for the most part, you know, the data is just coming out, but the things that happened in society to prevent COVID happened, you know, many of these were policies that were applied broadly across the population, but that doesn't mean the impact was the same for everyone. So much of what we are seeing, particularly for LGBT elders tended to be quite isolated on the average before. These are individuals who grew up in a very different time, were much less likely to have children, had peer groups that were heavily impacted by the HIV/AIDS epidemic of the 1980s and the 1990s. And so we know that pre-existing social isolation before COVID was only further compounded during COVID. And not to mention the technological barriers that are in place for many of our folks based on both age, but also income and access that way. So that's just sort of one example of how a population, how LGBTQ be particularly impacted by the pandemic, but that even within the LGBTQ community, there are these communities that are impacted differently. The only other thing that I would say is that, especially in New York and in large major metropolitan areas, there are good infrastructures for providing social support to LGBTQ people, but most of these rely on in-person gatherings to some extent, whether we're talking about LGBTQ bars, whether we're talking about community centers or community spaces or community events. And these were sort of all shut down and for the most part remain closed. And I don't think that they're quite as accessible to broad swaths of the LGBTQ population now in this sort of virtual environment. I work at a public health clinic, public mental health clinic in Washington Heights, and most of my patients don't have webcams or unlimited data on their cell phones. And so the idea of hopping on a Zoom call to attend a support group meeting is something that's not accessible for all folks. So I realize I haven't actually said very much about addiction, and I think there's a question coming up later on about it. So I'll say more there, but I think I've also gone 5 minutes. So I'll pause there.
Thank you, Dr. Kidd. I did have a question regarding the rates, or like the different rates of tobacco, alcohol, and other drug use in the LGBTQ population compared to the general population.
Yeah, and there are some interesting nuances if we look more closely at different subgroups of the LGBTQ population. For instance, when we compare sexual, so gay and bisexual men and other men who have sex with men, to sexual minority women, lesbian and bisexual women, and other women who have sex with women, we see differences in the kinds of disparities that we see. And an exemplary substance is the case of alcohol, where for sexual minority or LGBT individuals generally, we see higher rates of hazardous drinking. But when we compare the women to heterosexual women, and we sort of compare that disparity to what happens with men, the disparity for women is much, much greater. And that tends to hold true across a number of substances. In my work with trans folks, we've seen the same sort of disparity with transmasculine individuals, that historically, out of the HIV literature, we think of trans women as being particularly at risk. And that is certainly true when we think about HIV. It's certainly true when we think about violence victimization. But when we think about substance use, it actually seems to be that transmasculine individuals are at quite a high risk for problem drinking, for daily tobacco use, for heavy cannabis use. So those are just some examples of, even within the community, how there are differences in substance use patterns that we really still need to understand.
I also noticed you mentioned that people who are older tend to have more difficulty connecting with others through social media and feeling more isolated. In general, how has COVID-19 uniquely impacted the LGBTQ community and the population at large?
Yeah, so there are a couple of ways. So that was one example, I think, of older LGBTQ folks. There are a couple of ways in particular for trans folks that this has been, that have been uniquely impacted. One of those is the loss of support in the same way that we were talking about for older LGBTQ folks. You know, the loss of trans-specific support groups, the loss of trans-specific services, just the inability to interact with other trans people unless you live with them. But the other big thing is around gender-affirming healthcare. So in the early part of the pandemic in March and April, New York and most other states began to shut down elective surgeries, outpatient clinics, and this is starting to happen again. And gender-affirming surgeries and gender-affirming hormone treatment were sort of caught up in this, and there was a lot of debate about whether that should be considered elective or not. And I think most trans folks that I interact with sort of understand that, you know, the use of the word elective in that case. But we know that these are surgeries that can be really important for folks' mental health and for their well-being. And so to have a surgery that you might have worked 2 or 3 years to get together, meeting with multiple mental health professionals, a huge amount of money invested, suddenly canceled on you. And then to also not have the support of your family, biological and chosen, around you, can be really devastating for folks. And actually in some of the longitudinal cohort data that I've worked, we showed that individuals who lost access to their trans-specific support groups tended to do worse in terms of mental health distress and mental health outcomes during the pandemic than those who maintained access to those kinds of support services.
Got it. Well, thank you so much for talking about this very important topic, Dr. Kidd. Now we have our next speaker.
Thank you so much, Dr. Kidd. Our next speaker is Dr. Shabnam Shakibaie Smith. She is an addiction psychiatrist affiliated with Columbia University, and her talk is on addiction and pregnancy during COVID-19. Hello, Dr. Shakibaie Smith. She here?
Can you hear me?
We can hear you, yep.
I'm not sure how much particular data COVID, but I could, there is some data, and as we talk about, we could point upon those. So substance use disorder in pregnancy in general is a serious health problems and has severe implications for the mother, the baby, and also the society. And I personally got interested in this topic because during my work in research setting and in clinics, when I was working in a clinic in the Bronx and a grant, and I was working and also seeing patients in a research setting, I saw a lot of women who reported use during a pregnancy. They weren't pregnant at the time. And it was quite painful to hear their stories, how much shame, talking about stigma, how much they felt stigmatized and how much shame and pain they were experiencing and regret over having used drugs during their pregnancy. And that made me think that, to study this area more and focus part of my work on it. So in general, just a very brief overview of the epidemiology of substance use disorder. About 5% of pregnant mothers, they all report substance use, which is much less than their the proportion age among non-pregnant women. And it's a good thing to know that as the age of the pregnancy increases, in general, substance use disorder decreases. So like in the third trimester, the use is less. And in general, we see more substance use in pregnancy in younger women than in older women. Younger, I mean 15 to 24. There is treatment. As I said, there are complications for the mother, the baby, and the fetus. And also there are social complications. In general, substance use disorders, they all have, they increase the societal expenses in a variety of ways. There is treatment available, but one of the major hurdles during the COVID has been how to monitor pregnant women, who many of them also have co-occurring psychiatric disorder, and it's always important to assess for that and treat for both. How do we really follow them up? It's really hard. Many of them have not, many are not able to go out. They're pregnant, they don't want to get sick, and they're at home. Especially with alcohol use disorder, it has been a major problem. I personally have seen a lot of relapse among my patients, and I also have heard from colleagues who they have seen a surge in alcohol use disorder. It's in general in the population has increased, the amount of alcohol use, and the pregnant women are no exception. So this has been actually, I think, of all the patient populations that I see during the COVID, the most difficult population to really feel like I'm doing a good work and manage them better has been my pregnant patients. I had to ask them to go to for U-Talks, those who use other illicit drugs, and that has a risk to leave home and go get tested. And WHO in 2013 published a very comprehensive international report and consensus on substance use disorder in pregnancy. And majority of the report, one of the major factors in treatment of substance use disorder was that the women who use during their pregnancy are being provided the substances partners, mostly illicit drugs, less with alcohol. The need of pregnant women during COVID on their male partners had increased, as we have a lot of reports that the domestic violence has increased. And therefore, this has been quite difficult to, I don't have actual data on it. These are anecdotal reports and conversations. I haven't seen anything published yet, particularly about pregnant women with substance use disorder. But usually substance use disorder in pregnancy follows a general trend of the society. And
Dr. Smith, we actually have a question from Dr. Tricia Gibbs, and the question was, what are the risks of THC use during pregnancy?
That's a very good question. We don't know for sure, but the recent data in particular, they were talking about that the number of stillbirths who have used marijuana during their pregnancy has tripled. The multiple data support that. There are, and also the other thing is that usually in families that there's substance use going on, there's a lot of chaos and disorganization in general. And one of the problems with a lot of studies that we see, some studies have reported that there are cognitive declines in the offspring of mothers who've used drugs, including marijuana, during a pregnancy. They haven't been able to, when you factor in the social factors, they haven't been able to exactly determine that, but those reports are out there.
We heard a little bit about kind of marijuana in pregnancy. I'm curious about the treatment of, and you know, there's not many treatments for that except for, you know, psychiatric care. What are best treatments for opioid use disorder in pregnancy? Is buprenorphine better? Kind of what direction should people be going in?
I think that's a very good question. Again, there was a study in 2010 named the Mother Study, and in that study they realized, because babies of mothers who are exposed to opiates during pregnancy, the newborn goes through neonatal abstinence syndrome, and that has been a major problem because it requires hospitalization. In the Mother Study, they showed that, and in the study they had two groups of women who were already on either methadone maintenance or buprenorphine treatment, varying doses, and the result was that the babies exposed to buprenorphine in utero, they had fewer days of hospitalization and less severe neonatal abstinence syndrome or withdrawal. So both can be used. In general, the newer studies and the newer data favoring buprenorphine, but both are good. The problem with buprenorphine is that if the mother is using high amount of opiates, let's say 10 bags of heroin a day, it's really hard to induce that woman on buprenorphine without causing withdrawal for the mother and the baby. Therefore, methadone, depending on the clinical case, the choice we make is different, but overall, buprenorphine is favored over methadone.
Thank you so much, Dr. Shakibaie Smith. This is very informative. Thank you so much.
So I echo what Dr. Rockas said. Thank you again for the presentation and for your talk. And now we have our next speaker, Dr. Jonathan Avery. Dr. Avery is the Director of Addiction Psychiatry and the Associate Professor of Clinical Psychiatry at Weill Cornell Medical College / New York Presbyterian Hospital. And tonight, he will be talking on the current addiction treatments during COVID-19. Take it away, Dr. Avery.
Thanks for the kind introduction, and thanks for inviting me to be a part of this special panel. And a special thanks to Jose for putting it all together. I think we should really just study Jose. He has this unique way to connect people and ideas and make it fun and exciting for everyone. And so any event I'm in that involves him, it ends well, I think. But I think, so I'll talk about treatments a little bit in the setting of COVID-19. And I think it's been clear, but just to reiterate, we think substance use is increasing during this time, right? COVID-19 has all the risk factors for getting into trouble with substance use: financial stress, isolation, increased mental health burden. And so I think the early data shows increased alcohol use, increased opioid use disorder. And I think we can assume that for all the different populations that have been discussed so far. And I'm sure the data as it comes out will be increasingly concerning. And so as we think about treatments in this setting, and even before COVID, we have a couple problems. One is access, that a lot of the people who need the care don't get the care, right? Less than 10% of people with substance use disorders ever get treatment for addiction. And then we have the problem with us in that psychiatrists and clinicians don't often offer the evidence-based treatment for substance use disorders. And so our hope, and it's probably not going to happen right now during this COVID-19 environment, is that we can use this crisis, not waste this crisis, to make gains in both. And I think some of the ways that access has improved, even as people might not want to access it because it's different, is I think the increased use of virtual programming. And so this is true for 12-step work, which has shifted to Zoom. It's true for 12-step alternatives like Smart Recovery, for outpatient rehabs, even some programs that approximate inpatient rehabs one can now do from one's home, which I think is an advantage, although certainly not available for everyone for the limitations discussed earlier, including access to data and webcams. But I think that's one thing that's unique and different, and I've certainly seen people in treatment who wouldn't otherwise access it because they couldn't leave their couch or their home before COVID-19. And then as the psychosocial treatments go virtual during COVID-19, I think it's been increasingly easy, hopefully, to access some of the important medications for substance use disorders. Meds for alcohol use disorder, nicotine use disorder, but when we talk about opioid use disorder, it's especially important. And so during COVID-19, the federal government has eased access to medications for opioid use disorder. For methadone, the physical exam requirements have been relaxed and medication supply has been extended for stable patients, which is great news, long overdue. Methadone treatment has been stigmatized for too long, it's been too burdensome, and so hopefully people can take advantage of it in a more easily accessible and less burdensome way. We've also seen the DEA ease restrictions by allowing phone prescribing of buprenorphine. You know, Montefiore and Bellevue and others have, you know, allowed for phone-only services to folks even without insurance, you know, which has been especially important during COVID-19. And then the National Institute of Alcohol Abuse and Alcoholism created a database to enable treatment and support for alcohol use disorder. And so people are working on getting some of these treatments virtual. And, you know, we hear a lot in the future of addiction about ketamine, about psilocybin, about TMS. You know, you hear about these novel formulations of buprenorphine, be it the Sublocade or the Probufene. But I really think it's this access and taking the increased access during COVID-19 into the future that's going to do the most benefit to imagine. My hope is that post-COVID-19, we have the in-person, easier to access treatments in combination with some of these virtual treatments. And so that people across the socioeconomic spectrum, despite and barriers that exist to getting addiction care, can be decreased, and so that people can access care more easily, and more than the 10% of people that do get into treatment can get into treatment. But right now it's a worrisome climate. There's certainly more substance use, but hopefully we won't waste this crisis and take advantage of some of the shifting nature of addiction treatment to get our patients the care they need.
Thank you, Dr. Avery. I liked what you said about not wasting this crisis and actually using it. And a lot of things that are on a lot of doctors' minds is, will telehealth services for addiction continue to be utilized or valued even after COVID-19 as sort of like the pressure of the pandemic starts dying down?
I mean, I have to be honest. I didn't think telehealth would be so successful. And I mean, maybe that makes me the old person in the room, but I was suspicious that it would work. And I've actually found it to be much more successful. I think the data will come out that it's more successful. Even these sort of auxiliary services, like we have a peer program here at New York Presbyterian that meets people in the emergency room after overdoses. And we thought that wouldn't be effective telehealth services, but some of our early data on it shows it's been as effective with telehealth, even in those acute crisis moments. And so my hope, I mean, we just need to give people a menu of options. And so hopefully these government restrictions that have been eased aren't retightened. You know, I would take some of the state licensing things into consideration for that as well. My hope is that it will continue, because there's definitely some folks that feel, especially the younger generation, that feel more comfortable engaging in this way than, you know, schlepping up to my office to come see me and sit there.
Yeah, and I think another part of, you know, addiction treatment in addition to medication is detox and rehab. And I know, like, there's been a lot of detox programs closing, and I'm wondering, in terms of rehab services, you know, what the future of that is going to be like moving forward.
Oof, rehabs, huh? I mean, John Oliver was right to rant on the rehabs if you haven't seen his rant on them. I mean, they're very problematic. And, you know, even before COVID-19, their ability to do evidence-based care, especially for opioid use disorder, was bordering on criminal. And so it's what I have seen in some of the rehabs that I've advised, or some that I've sent folks to, is that people that weren't offering evidence-based care in the rehab, hopefully they can now through telehealth services. Like, I've had people go to rehabs and take advantage of telehealth psychiatry or telehealth buprenorphine inductions from an inpatient rehab. So my hope is that it's used that way. But and that will make it better. I do worry, though, especially as we get into COVID-19 and beds are shut down, that people who need detox aren't going to present until they're too late to these hospital settings and with the closing. But hopefully in the long run, it'll allow for more evidence-based care to be everywhere.
Awesome. Well, thank you so much, Dr. Avery.
Sure.
Our last speaker is Ms. Berthy. She's a drug policy organizer at Vocal New York, and she will talk about addiction drug policy legislation during COVID-19. Welcome, Ms. Berthy. And thank you again, Dr. Avery.
Thank you so much, and thank you to everyone before me that spoke. I guess in the interest of time, I'll just dive right in. So I am the drug policy organizer at Vocal New York. Vocal New York, just a quick background in case folks aren't aware of what we are. We're a grassroots organization working to end the war on drugs, homelessness, mass incarceration, and HIV and AIDS through building a movement of directly impacted folks. We've been around for about 20 years. We originally started as an AIDS housing network, but quickly moved to encompass the larger issue areas I just named because our founders very much were cognizant of the fact that HIV and AIDS and the crisis was not sort of an isolated public health issue, but rather a consequence of all the things I just named. And those 4 issue areas, just to sort of quickly break down our organizing model, each issue area has a union. So I help organize the drug users union. We have a civil rights union, a homelessness union, and then a positive leaders union. So for folks that are HIV positive. And really we're modeled after just traditional grassroots organizing, direct action, AIDS activism, and Black-led social movements. But the foundation of our work is really centered around this idea of nothing about us without us. And just the idea that for far too long, and the reason why we are in the numerous crises that we are currently in is really in part the result of the fact that so many people in positions of power are not folks who are directly impacted by the issues that they are making decisions on. So at Vocal, we really stress to our members and leaders of our unions that their lived experience makes them and so in a way I've been thinking, because you all do a lot of research, which is incredibly important, but I think as we all know, especially with overdose data, there's huge lags. And so Vocal New York and this kind of organizing is kind of a way to mitigate that lag and keep your finger to the pulse and keep up to date with what's really what the things that people are really facing to on a day-to-day basis. So the users union, like I said, is made up of former and active drug users. And in terms of legislative platform, it's really centered around, I guess, 3 sort of umbrella goals is how I describe it. The first one being removing drugs and drug use from the criminal legal system entirely. The second one being ensuring universal access to harm reduction tools and services. So things like syringe exchange programs, and just Narcan, any drug user health tool, as well as ensuring universal access to medication-assisted treatment. And then the third is to fight back against any pre-existing or newly introduced drug war policies or policies that uphold the rhetoric of the drug war. So things like homicide by distribution bills, anything really that embodies the drug war. But as many people here, I'm sure, also experience, COVID sort of switched us into crisis mode response. And in terms of that, I would say that the things that the Drug Users Union at Vocal and Vocal in general have been fighting for or fighting back against are 3 big things, but protecting the funding for harm reduction services and tools. So there's currently a syringe exchange shortage across New York State, and it's pretty dire. Many of the folks that make up our union are folks that lived through the HIV and AIDS. So for them, it's like really triggering because they're seeing things on the ground that they just have not seen in 20 or 30 years and thought that they were never going to see again. And then maintaining safe and consistent access to medication-assisted treatment, specifically methadone, is something I've been doing a lot of organizing around. As it's been said before, the government did ease certain restrictions around it, which is great and definitely historic. But there's a lot of deep structural stigma that still exists within administrations at methadone clinics. And so what that has resulted in is thousands of vulnerable New Yorkers still being forced to come in every single day to their clinic, oftentimes from, hours away, which is just unacceptable. And there exists like sort of no collaboration or communication between the clinic and the clients. And then really we are trying to push leaders and researchers to think more about stimulant use, which is like the third wave of the OD crisis. And we really think that like, because we don't even yet have secure universal access to MAT disorder, we're already behind an entire wave because now we're seeing overdose data that's clearly indicating that the majority of fatal overdoses are the result of drug use that involves stimulants. So we don't yet have like a bill on that, but that is something that we're really starting to think about and formulate. And I think that was a very big, fast crash course. But I guess I'll just say, as many people have already said in their own words, but like COVID has just crumbled the already fragile drug user health infrastructure and really exposed how arbitrary and nonsensical and frankly violent the laws that we have in this country around drug use and drug use like treatment are. So yeah.
In a lot of ways kind of that your organization is helping people with addiction during this really tricky time. I'm curious how individual psychiatrists or even some of the institutions of which we're a part can use principles of harm reduction that you guys are using in their own practice or their own institutions.
Yeah, so I think like traditionally with any institution, there's like a long history of sort of like imposing what the people in positions of power think are best population, I guess in this case, people who use drugs. And really, I would say that harm reduction pushes people to be more collaborative and reimagine what care looks like and center care in the person that you're caring for and to take direction from them rather than to impose direction onto them. So yeah, I would say that's like a big one.
We have a question from an audience member, Ms. Leslie Guys. She's asking, Dr. Leslie Guys, sorry about that. She's asking, can you comment on supervised injection sites? And
yes.
Yeah.
That is overdose prevention centers is a bill that we've had introduced for a couple of years now, and something that we've been fighting for a long time. I'm sure some of you have seen the coverage most recently in Philly, where I actually used to work in Kensington, where they're pushing to open up the first OPC for the country. And there's a lot of pushback. The mayor, Bill de Blasio, is in support of it, but Governor Cuomo is not in support of it, even though he's had several opportunities to sign off on them, which is incredibly frustrating. And I think incredibly frustrating for folks in the wake of COVID, because as I'm sure many of you also experienced with your clients, there was just so many nights like staying up all night worried sick about members and leaders and participants, because Vocal also, I forgot to mention, has a syringe exchange program. We do direct services. And if we had overdose prevention centers in this country, in this city and state, that would be one less thing that we would have had to be freaking out about at this time, right? Because we would have known that there would have been a safe place for people to go and use their drugs and not die. And the same can be said for safe supply. we had a safe supply, that would definitely have mitigated a lot of the stress and anxiety that we've been experiencing.
Thank you so much. Another question is for Dr. Avery. Dr. Avery, this question is, what is the future of inpatient rehab services after COVID-19?
What do I want it to be, or what is it? I mean, I imagine it's a very difficult space to talk about because, there's so many problematic facilities that exist, and where there's such a big business as there is an addiction, I think there's going to be tons of people doing all sorts of problematic things for rehabs. And it's my hope. The hope is that we can get facilities that treat co-occurring disorders, that provide the evidence-based care, that engage in harm reduction, that don't sort of adhere to one for their clients wherever they're at. And, that would be sort of an ideal setting. And they would also be available by insurance and not cost, $70,000 to $100,000 a month, and that anyone could access this quality of care when things get wrong. And I mean, that's why I always like talking in Europe, where they have these therapeutic communities that are free, that people can go for multiple years, that are these beautiful communities. Things have been decriminalized. People are diverted to treatment. And so what we've got to get away from is long-term therapeutic communities in the United States being jails, or people going to rehab paying $100,000 are the only ones getting the good care, and that we have sort of an evidence-based spot for people to land when things aren't going out in the world. How to get there, though, it's harder during COVID-19, and how to get there, I think, has been a goal from our end. I think I'm preaching to the choir in this room, but how to get there is going to be tricky.
Thank you, Dr. Avery. So the next question is actually from Dr. Leslie Guys. Hi, Leslie. Are you in Brooklyn or in Hawaii?
Hawaii, on Maui.
All right. So anyway, you have a question for Dr. Shakibaie Smith. Do you want to ask your question?
You're on
We
mute.
can't hear you.
It was about women with opioid use disorders, Suboxone versus Subutex, and also the risk of adherence with buprenorphine versus methadone, and the risk of opiate withdrawal for women with opioid use disorder and miscarriage with various treatments, and the risk of withdrawal with different treatments for opioid use disorder, which is specific to pregnancy, where withdrawal is more, as far as I know, more dangerous.
So good to see you. In terms of, I guess a bunch of questions. So in terms of withdrawal, we really want to avoid withdrawal in pregnancy. Withdrawal, therefore the baby fetus is going through withdrawal, and withdrawal in the fetus is quite dangerous because in preterm labor, stillbirth, and some reports reported brain bleed in babies who were going through withdrawal. They could have seizure and then brain bleed. So withdrawal is something that we really want to avoid in a pregnant woman. And recommendation is that as soon as the mother feels uncomfortable, to address that. In terms of which one is better, in terms of the CTN actually has a new that they're comparing the implant of Subutex versus the sublingual. In general, in pregnant women, adherence to treatment is pretty low unless they have to be either by family services or by law. They have to be receive treatment. In general, the adherence is pretty low, and the WHO study suggested that if pregnant women are able to have housing of their own, the adherence to treatment improves because they're not dependent on their partner, and usually partners are the ones that provide them with drugs and sort of in exchange for sex. So there was another question there, and which one was it? I think I missed the question. Adherence, which one is better, methadone and buprenorphine? In the data is almost the same. Usually pregnant women respond better in treatments that are more comprehensive. They have to attend more contact with provider is better for pregnant women, and especially if other social services are available for them.
Thank you so much. So our next question is for Dr. Lewis. The question is, what role does intersectionality play when engaging patients with substance use problems?
Thank you for that. Just to kind of, I'll answer that and try to encompass a lot of what the previous speakers talked about, and which is all has been very thought-provoking, and I appreciate it. I think the biggest thing that we have to think about is access to care and who is able to get into treatment and be retained and adherent. And I think that when we talk about intersectionality, there are patients who are contending with maybe perhaps stigma, and then there's patients who are maybe contending with things that may not be related to stigma, but it's still intersecting, because you can have intersectionality where I'm experiencing stigma because of, or discrimination because of my race, because I'm LGBTQ, but there's another intersecting status, which may be poverty, which maybe I'm experiencing stigma or not, but it's intersecting within all of that. And so when you add that on top of it, then, you know, you've got to kind of think about all these things in comprehensively. And I think harm reduction answers that question entirely. And I'm happy that we have someone from Buckle, New York here, because I think that is the main, the short answer to it. I mean, what we're finding is that patients who are homeless, patients who, I shouldn't call them patients because they're not patients. They haven't accessed care, and they haven't been able to access care pre-COVID, and they're still unable to access care because they don't have unlimited data on their phones. And a lot of us were thinking that, oh, telemedicine, telehealth, you can have video, you can see. Well, it's not even about having an iPad or video. It's about having access to data. People, and people were the working class poor, people were really on the edge. They lose their jobs, and now they can't even pay for their phones. So a lot of people lost their phones. And we saw an increase in people using the free, the New York NYC Wi-Fi to call doctors and to get access to care and to use our virtual clinic at HAC at Bellevue. So I really appreciate Dr. Avery talking about using this as an opportunity, because if we can get access to free Wi-Fi in communities that's not just the Upper West Side or Upper East Side, but in the South Bronx. I mean, how come we don't have free Wi-Fi? Again, this is structural, and this is a problem. So all of these things matter. They all intersect. And I think that we have to make sure that we, I just dropped my mouse, that we're thinking about all these things all the time. And we do it with humility and meeting people where they're at. And I'll stop there.
Thank you, Dr. Lewis. Our next question is with Dr. Jeremy Kitt. The question is, the differences in substance use for LGBTQ folks compared to cis heterosexual folks. What about that?
So I'll also answer that and sort of weave in a couple of other thoughts as well. I mean, I think one of the things that we have to pay attention to, and I think we need to do a better job in research, is paying attention to intersectionality in our research with LGBTQ folks as well. I mean, one of the problems with a literature that relies primarily on teeny samples that are convenient samples is nobody ever looks at data in careful and nuanced ways. And I think there's an assumption, I think, that that various researchers have about how these intersectional oppressions or stigmas sort of play out. But I think one great example of sort of an unexpected finding has been in the look at some alcohol disparities and comparing different racial ethnic minority groups of LGBTQ folks and those disparities to white LGBTQ folks. And so I focus a lot on alcohol, and there had been data showing that population studies, so we're not talking about LGBTQ folks here, but Black individuals having lower rates of alcohol use disorder compared to white individuals, and those same sort of disparities not existing in that. But when we looked at Black LGBTQ folks, we found that those disparities were actually even greater than looking at the white LGBTQ folks. And I think that compared to their white heterosexual cisgender counterparts. And so, you know, there's a lot more work that needs to be done there to understand that. And so I'm doing some qualitative work now, but I think the other way that we can understand that is some of the things that Berthy was saying, which is, I think, to involve the community and involve more collaborative advisory boards in our research studies to actually get people involved in the data.
Thank you, Dr. Kidd. That's a segue for Ms. Berthy. Ms. Berthy, this question is for you. How can psychiatrists or psychiatric institutions incorporate the principle of harm reduction and the Vocal New York Users Union in their practice?
Yeah, so as I said earlier, and I think as was just said before me, it's really about making it a collaborative effort rather than like a one-way interaction. For far too long, institutions that hold a lot of power have operated without at all consulting the folks that they are serving. So people who are actually directly impacted by any of these issues that we're naming are truly the and that's really what harm reduction. The phrase "meeting people where they're at" is something that's thrown around a lot to the point where I would even argue I don't know that we even know what we're saying when we're saying that. But it's a guiding principle. And for me, I think meeting people where they're at isn't necessarily like even, I don't know. I think it's about collaboration because everyone can offer things, but we should really be prioritizing how an individual imagines what stability looks like for them and what health looks like for them. Just because, again, as many people have said in their own ways, addiction is something, and drug use and drug use disorders are something that it's really complicated. But oftentimes, having spoken to at this point, there's like a clear correlation between sort of the environment and people's drug use. And so I think there is a tendency in maybe larger, more mainstream, so not necessarily you folks, like psychiatric institutions or just medical institutions in general, that sort of pathologizes drug use, when really when you sit down and talk to people who use drugs and approach it with an open mind, it's actually quite logical why people use drugs, right? So like the intersecting of poverty, any number of the intersections. So sorry, that was a little bit of a ramble, but that's how I would encourage psychiatric institutions to incorporate harm reduction.
Thank you so much. Thank you so much. So seeing no more questions or comments on the side, and I'm being mindful of everybody's time, I just want to thank all our speakers who had made this lecture very informative talk. Thank you, thank you. And I want to thank all of you guys for spending this evening with us. Good night.
May I say something before anyone goes?
Oh, sorry.
Thank you very much. I just wanted to plug in for the Women's Committee. I'm the chair of a Women's Committee. Please, we want new blood. Contact us. We want more members. Please contact us. We want new members.
Yes, Women's Committee. Yes. Shabnam is the chair right now.
You can go ahead and email us at info@nycpsych.org if you're interested in joining. Yep.
All right, everyone. Good night. Stay safe and well.